Hello, interwebs, internets. Welcome to the Friday Oncodata podcast with LARVOL. I'm Mark Gramling, VP of Oncology at LARVOL. And every Friday we talk oncology data, AI data with oncology, or more oncology data with AI, at least the past few weeks. And to that end, on that topic, happy to have back Dr. LoAIza-Bonilla joining me today. We talked last maybe November 2024 and had a good time. So just like to welcome you back, Arturo. So thanks for joining. And if you wouldn't mind giving our podcast audience a quick introduction to yourself, and we can chat from there.
Absolutely. Thank you, Mark, for the opportunity again to be here in the podcast. I'm Arturo LoAIza-Bonilla. Have a couple of roles. I'm a medical oncologist, and I'm the network chief at St. Luke University Health Network. Also, the co-founder and chief medical officer of Massive Bio. So I wear my entrepreneurial hat and physician hat and advocate hat, and I love to have too many hats. Not as fancy as the LARVOL one, but once again, one of those things that is I always want to keep myself busy understanding what's happening in the field, in the intersection of technology and care delivery. So nice to be here again.
Well, certainly appreciate you being here. You mentioned the St. Luke's and Temple, and those, I guess, are new since the last time we spoke. I feel like this is an inverse job interview. I'm not going to ask you what motivated you to do that, because that's not my role, but would love to hear about, just since we are catching up, what's going on at your new roles.
Yeah, absolutely. So as you know, I wanted to keep, even though I have an entrepreneurial side and I can be doing this 1,000%, which I still do, I wanted to keep myself understanding the pain points in the care delivery, right? So I always wanted to be an oncologist, so I will always be one. And as such, I was given the opportunity to lead the program at St. Luke University Health Network, which is actually a 16 hospital network in the Lehigh Valley, all the way to New Jersey. And it's a great opportunity for me because I was able to, it is actually the most integrated hospital in the nation in terms of data. So it's the most wired. And of course, we have Epic, but we have a bunch of AI algorithms implemented, which to me, that was a major opportunity because I said, okay, yeah, sure. If I have an institution that is nimble, that is academic, that has fellowship, residencies, and all that stuff, and we can use AI for, on a daily basis, I'm all in. So I'm just growing the program. And so whoever wants to learn about my job on that side, happy to. Of course, I'm always growing the program and finding oncologists and other stuff working with me and research. So yeah. And in the meantime, I have an appointment at Temple as faculty. So I'm teaching residents, fellows, and medical students, keep publishing, and continue to do my work at Massive Bio, bringing clinical trials at scale using AI in the oncology space for everyone now in 17 countries. So yeah, I've been busy as you can imagine.
Certainly sounds it. I hate to ask such a dense or almost naive question when you say using AI on a day-to-day basis, from I guess, I hope not putting words in your mouth, at a point of care. I was wondering if you could expand upon that a little bit, just because from my side, we think about what we can do with AI in terms of outcomes data, in terms of making outcomes predictions, in terms of AI. Right now, we use it on things looking at digital opinion leaders' reactions to data. I guess I don't think about it as where AI is on a day-to-day basis, even at a patient interfacing level. So I guess I'm putting you on the spot, but I'd just love to hear a bit about, because that's not the way my brain thinks about where AI is in big data. So there was a question in there, I think.
No, I get it. So, real-time applications that we actually use an AI for something meaningful. So the answer is yes. There's a couple of angles that we are doing it at St. Luke's. One of them is on the medical education side. We actually have a full curriculum for the medical students at the Lewis Katz School of Medicine with Temple, where we actually give them a full module about prompt engineering and using it for generation of data, summarization, presentation, how to use AI in a constructive and educated fashion. So that's part of the things we're doing now. We just had the Latino Medical Student Association conference in the Northeast in Bethlehem just last week, and we're able to actually show a workshop on AI in healthcare with a focus on oncology, as that's my area of expertise. So that's one component that we're doing on the education side. On the delivery of care side, we have a very good relationship with Microsoft and other developers of AI algorithms. So we have ambient AI aligned with our Epic. If we want to use the DAX Copilot with Nuance. We had the ability to do also the sepsis algorithms for the hospital, for example, and management in the ER to get us, real-time opportunities for patient optimization. And we also are deploying a number of algorithms on the radiology side and building our, at least in a nascent way, our own foundational models. So we're in conversations with Microsoft and their foundries and everything we're doing to set up our own ability to use the data that we have from very robust, diverse populations to use the algorithms in a sensible way. So a lot of opportunities here. We use it in trauma. We're able to detect also things with EKGs. We use it in cardiology as well for echocardiograms. And now we're entering the world of clinical trials, and of course that is very close to my heart, how we can use it for trial matching and for optimization of patient workflows. So digital pathology is another component we're using. We have a very good program with Helix for patients testing themselves for ancestry and genetic abnormalities, and we're looking forward to using analytics and deep data for better insights for those patients. So a lot of things and opportunities to grow in that end, but we're already using them, which is very cool because we have a full committee actually system-wide that is analyzing this on a bi-weekly basis. We have a repository of AI tools that we are leveraging that from those approved by the FDA and others upcoming, including some clinical trials. So to me, it was an amazing opportunity because I can really use AI at the community base, but also with the academic flavor. So it was the best of both worlds, and something that I'm very excited to work on right now.
Well, I guess the way you phrased it, being at the most wired hospital system seems like the absolute appropriate place for you, Arturo. So that makes sense. I guess it's sort of maybe it's a natural transition. Speaking to optimization and trial matching, maybe that leaps over to, since we're catching up, to see if the updates that are going on your entrepreneurial side at that massive bio, and we'd love to hear any new developments there. I know you've been well, of course you're going to be focused on AI and clinical trial matching, so how about we start with that as a premise, to see any updates with your company and chat from there.
Yeah, no, I'd appreciate that, the platform as well. So since last year we spoke, so at the beginning of the year, we got a shout out from the Cancer Moonshot for what we call the pre-screening hubs using digital health platforms and AI. So imagine, any patient, no matter where they are in the cancer journey, they enter those pre-screening hubs and we can monitor the patient journey. And as soon as you have a change on, your line of therapy is not working, or you have a recurrence, or there's a need for a clinical trial, we can kind of refresh that and give the patients the opportunity to seek for options in real time. So we're building those at scale now with thousands of patients coming to the platform every week now. We also won the UK unicorn as best company for AI. So we're featured by the BBC, and we also had a good partnership that just launched with the American Cancer Society. So as you know, the American Cancer Society, the most prominent patient advocacy organization in the world, I may say. They always help patients to find clinical trials, even before Massive Bio was, inducted, even though we've been 10 years in the space. But they saw an opportunity to maybe leverage all the patients that they come their way and use AI as a use case. And we have been privileged to be part of that initiative called the ACS Acts, launching in the Northeast first and nationwide roll up in the next couple of months, where basically all the resources from the Cancer Society in lodging, in helping the patients navigate all the different issues that happen with cancer care, while they're also powered by Massive Bio in terms of generating AI clinical trial reports. So every patient get the access to those clinical trials in real time. No matter where they are, where they're coming from, we help all of them to get a report whenever they need it. So we're very excited about how it's happening so far. We have a very good receipt of this initiative, and now we just is excited about seeing that we're really realizing what we dreamed many years ago of getting every single patient the opportunity to know about the trial options, and appreciate the partnership with ACS for that. So as you see, a lot of good stuff happening, and more to follow for sure.
I think my theme of the day is asking almost silly questions, but I'm going to ask it anyway. So we just think about, I think people see AI as two different things. So I'm sort of going back in a way to my prior question about thinking about patient level versus structural AI. So when you talk about, people being able to come to these decentralized, it's not decentralized, excuse me, but these pre-screening hubs, where's the preponderance of the AI application? Is it in your report generation that feeds forward, or are there elements of AI-enabled LLM, perhaps there's LLM models that are enabling the input of data coming from the patients? I'm just wondering is it a two-way street? Is it a 80-20? I like to think of things in sections, maybe info in versus info out. So my other phrase of the day is there was a question in there, but what's the focus right now with Massive Bio?
Yeah. So of course, we've been trying to use AI from the very beginning before LLM became a thing. But of course, now that they're available, we are leveraging all of them in real time for our different agents that do different functions of all the steps that take for a clinical trial. So it takes about 41 steps for a patient, since identification to the patient and actually enrolling to the trial themselves. And we have agents that develop different parts of those steps. So one is like connectivity. Once the patient wants to know about Massive Bio, we have the ability to explain that with the chatbots. So we use LLMs for that as well, and we're integrating it with also voice models. For example, 11 Labs and others that are able to give kind of like voice to those recommendations. We're using AI as well to be agentic, to sign out the patients to in our own systems, being able to extract the clinical record through APIs or even just through faxes, and structure everything and put it into the platform, and generate those parameters that can be used for matching on the Synergy AI platform. But something that we understand end to end is that we have to have full connectivity with the LLMs that are happening in the whole ecosystem. And I was interested, for example, a few days ago, Anders Karpati, he said, all the content that is being built right now on the 9% is still built for humans, when we know in the future with agents and LLMs, it has to be the attention should be mostly on LLM. It should be LLM-based content, because LLMs are going to read LLMs. So we need to have that ability to connect those dots. So we're generating content as well that is leverageable by any other platforms that connect with us. So we're connected with CRMs. So CRMs are just, for example, Hotspot or Salesforce or Viva, all those repositories that are able to track, patients' journeys and customer satisfaction and client data so they can be interoperable. The same way we are interoperable now with, with Epic and with Cerner, and we want to see how Oracle with their Cerner AI is moving forward, and so excited to hear all these things happening in the space. We want to generate the same. So I think the AI in the past used to be mostly initially for these kind of fine-tuning the models to be able to match patients to clinical trials amid data drift over time with temporal changes that happen when the patient changes, the condition, or the trial opens and closes, or there's any changes in the country or whatever. But also now the AI is bidirectional. We can extract data from the whole system, but also we're giving data to the system back that could be used for multimodal foundational model generation. And we want to use it also for analytics. So we can create these multimodal predictive and prognostic assays, you may say, that individualize to each person, so we can eventually become much more robust in terms of generating maybe digital twins, algorithms for trials, algorithms for also individualized therapies based on genomics and changes that happen in the DNA levels in drug discovery, right? So all those things are happening in real time, and it's hard to keep up. You have to read every single day. So every day I'm like checking and driving my team nuts, but it's all good.
Well, fair enough. I think I set up a false premise in my question that if it's one way or another, obviously it's not bidirectional. It's all sorts of directions. So, but I do really appreciate walking through some of those elements. I think sometimes when you sort of break it all down and think all of the steps for a patient and what they need to go through to be to be matched to a clinical trial, the way you broke that down sort of in a strange way from AI sort of reminds you of the humanness of it and the complexities that go into finding best care. So on that, what I'll call a positive note, we'll leave it there because this is the shortest podcast in the history of podcasts. So thank you, Arturo, for joining me. Obviously, a man of your many hats is probably too much to cover in 15 minutes, but maybe we'll talk in another couple months like we did before, and we can reconnect soon. So thanks, Arturo. I appreciate you, sir.
As always, a pleasure being here, and happy to support LARVOL and all the good work you're doing too.
Thank you, sir.